Presentation number 12, GIT, CT, and MRI and GIST in GIST, gastrointestinal stromal tumors, prepared by Prof. Sharaf and revised by Prof. Hani. Here, a 50-year-old man with anemia and abdominal pain undergoing CT. The axial CT shows a lobulated submucosal gastric mass. The differential diagnosis is a gastrointestinal stromal tumor, GIST, lymphoma, less likely to be adenocarcinoma, but may be deposit. The key point is that most of the tumor is bulging out more than inside the stomach, and thus it has an exogastric and endogastric components which are characteristic for the GIST group and lymphoma. Metastasis, subserosal metastasis, can give the same appearance, but adenocarcinoma is more likely to be confined to the lumen of the stomach, except if there is direct extension to the surrounding. GIST tend to appear as a large heterogeneous exoenteric mass with well-defined margin. The lesion may be hypervascular after administration of contrast. The lesions can have central fluid attenuation, sometimes can ulcerate and have calcifications. GIST ulcerations like leiomyosarcoma, for example. GIST most commonly occur in the stomach and then in order of frequency in the small bowel, large bowel, and esophagus. The most frequent metastatic sites are peritoneum and liver. The presence of calcification helps to distinguish from some cases such as lymphoma. Of course, lymphoma will not show calcification. Biopsy may be required for the diagnosis. So being exoenteric and as well as endoenteric give the possibility of being GIST or lymphoma or less likely submucosal deposits, but far is the adenocarcinoma. The presence of calcification excludes lymphoma and usually occur in the stomach in order of frequency, small intestine, large intestine, and esophagus. 60 to 70% of GIST occurs in the stomach from the muscularis propria interstitial cells of Casal, which are pacemaker cells for the gut movement, and thus show characteristic subepithelial neoplasms. Can be extraluminal, intraluminal, or both. In this case, they have the dumbbell-shaped pattern, while 79% of them are exophytic in gross. Small tumors are often of homogeneous density or homogeneous signal intensity. Large tumors tend to show lobulated margins, hemorrhage, ulcerations, heterogeneous enhancement, and thus may cause bleeding, cavitation, necrosis, and thus fistula can form. Large size hepatic metastasis and presence of wall invasion often suggest a high-grade GIST. Malignant GIST commonly metastasize to the liver and peritoneum. Metastasis to the lymph nodes are rare. This is an appearance of a large mass which is seen as a filling defect within the stomach. Of course, the extent outside the stomach could not be assessed. GIST, smooth outline, usually lobulated mass. Sometimes you can find an ulcer with barium fleck in between, appearing inside. Here is the large lobulated mass with the ulcer showing the fleck of barium within. Of course, there is extension here outside the gastric outline, exophytic component. Now this one has very big mass with ulcer, very big mass with areas of hemorrhage and necrosis and cystic and cavitation. These areas, small areas scattered here. This is with ulcer, and this may lead to fistulation, cavitation and fistulation. This one with necrosis and fistula to the stomach. Leiomyoma originates from the muscularis mucosa or muscularis propria, well differentiated, show similar microscopy appearances with gastrointestinal stromal tumors, but show positive staining for smooth muscle, actin, antihistamine at immunohistologic chemical examination. Gastric schwannoma arises from the neural plexuses. They manifest as subepithelial tumors. So these are the list of the subepithelial tumors showing minimal enhancement during the arterial phase and delayed enhancement during the equilibrium phase. Malignant nerve sheath tumor may show necrosis and heterogeneous enhancement. So early minimal, late enhancement to occur in gastric schwannoma. We have here mass exoendo, mass exoendo. This is a Gist, another example of Gist. When we give contrast here, the change is not so significant. So the presence of minimal enhancement in arterial phase, but if we follow, we'll get more enhancement seen in the equilibrium phase. This is a malignant schwannoma or Gist, large mass with central necrosis and hemorrhage, and here is the arterial phase. Early there is no enhancement or minimal enhancement. Here is the equilibrium phase, and we'll start to see some generalized enhancement of the tumor, characteristic of schwannoma. Early minimal and delay or equilibrium phase, more enhancement is seen in schwannomas. Neuroendocrine tumors occur in the appendix, followed by small bowel, but more gastric endocrine tumors are found recently due to endoscopic examination. They manifest as, again, subepithelial masses with avid enhancement. This is the mass. Here it is. This is a malignant gastrinoma with liver deposit. This is a gastrinoma, and these are the deposits. Both enhance intensely. There is intense enhancement of the deposits, like this one and that one. This is the mass, and this is the deposit, gastrinoma. So now we can get some differentiations due to the appearances, the behavior due of contrast after contrast injection. Minimal enhancement followed by more enhancement at equilibrium may suggest schwannoma. Enhancement intense is seen in gastrinoma and its deposits. Gastric lymphomas account for 1 to 5% of malignant tumors of the stomach. Due to submucosal spread, gastric lymphomas appear as thick gastric walls or nodular gastric walls with perigastric lymphadenopathy. Sometimes gastric lymphoma can form focal mass which mimics subepithelial tumor. Again, the exogastric, endogastric with enlarged lymph node at the retroperitoneum, enlarged lymph nodes. This is the mass, gastric lymphoma, mainly outside the room. When large epithelial mass of the stomach is found on CT or MRI, it is more likely to be GIST, especially when it possesses extensive necrosis, fistula formation, or hepatic metastasis. And we have seen the gastrinoma with deposits, we have seen the large malignant schwannoma, and the benign behavior of leiomyoma, and we have seen lymphomas which do not calcify and usually associated with enlarged lymph nodes. But in GIST in general, no lymph node enlargement, and these are characters of epithelial tumors or carcinomas. In the presence of enlarged lymph nodes are characters of carcinomas, and the presence of gastrointestinal obstruction denotes that the lumen is involved, encroached upon, and obstructed, and this is again a character of carcinoma. Thus, GIST does not produce evidence of gastrointestinal tract obstruction in early phase. Here we have two examples. One of them is bulging inside the lumen and eating the mucosa, and one here the mucosa is intact while the submucosa is proliferating, producing a large mass which is bulging outside the stomach. This is the example of carcinoma, and this is the example of GIST tumor. And here you can see the inner hemorrhages, necrosis, and maybe ulceration. Lymphoma is behaving the same as GIST. We have extragastric or exogastric or exophytic and endophytic component, endophytic and exophytic, and it can produce, of course, encroachment on the lumen. In sarcoma, this is a large mass, mainly out, somewhat in, so showing necrosis and hemorrhages and showing lobulated appearance. And this is another form of GIST. Carcinoma is usually results in intraluminal mass, and here is filling the region of the fundus. Exogastric, mainly exogastric, but some may encroach in the lumen and encroaching in the lumen, and this is lymphoma, mainly exogastric and encroaching in the lumen, and this is GIST. But here it appears tubular and is associated with enlarged lymph nodes here and there, denoting that it is more with lymphoma. In GIST, there is definite necrosis, hemorrhage, and maybe ulceration on the surface towards the lumen. Thank you.